Good evening. Good evening to all those who have joined. So, I am Vishnu, junior resident here at the Department of Emergency Medicine. And today we are going to be talking a little bit of food injuries. First thing I would like to say is I'm not an orthopedician. Second, I would like to say is I'm not an expert also here. Whatever I know is from very limited cases that I have seen personally. Majority of thing is just theory to me as well. I'm not going to be talking extensively about what are the different injuries that you can have, what are the different things and what not and what yes. But the main point is just driving home some important common injuries that you shouldn't miss. Or it is good that you pick up these. So first of all, I would like to start with this particular X-ray. Uh, can anyone say what is wrong here? Is there an obvious fracture or anything that you can see? And second thing is, this is part two. We had already discussed about ankle previously. That was also a short session. This is going to be an even shorter session. We are just going to cover three common things in the foot. So anyone can give uh, an idea as to what is happening here? Any fracture or dislocation or anything that you are able to see? I know there are very few people. So I'll just wait for 10 seconds so that you can have a good look at it. If you want to comment, please comment. I won't be able to see the dialog box, so it will be better if you just unmute yourself and say it. Else my sir will convey whatever is being told on the chat. Any fracture or dislocation. Yeah, those are the things we look at. Sir, has anyone told anything in the group or shall I just go ahead?
No, you can go ahead.
Yeah. So thing is, if you look closely, I'm unable to get onto the pinpoint here. You can see that I'll just escape from it. Are you able to see the screen right now? I hope that you can see the screen. And around over here, that is at the head end of the first metatarsal, you can see two small opaque oval shaped stuff. And those you can call it as sesamoid bones. And you can see that there is an apparent fracture of the sesamoid bone over here towards the, I would say, the lateral part of the head of the first metatarsal. There is a sesamoid bone fracture that was being told. So, is that a fracture or not? Was the question I wanted to ask. And since there are not many people over here, I will just go ahead and say it, that you don't look at the X-ray first. You look at the patient. You look at the patient, and if there is a fracture, there has to be a localized tenderness over there. This patient did not have any tenderness at that area, so that is not a fracture. Simple and humble. What did this patient actually have? This patient actually had a Lisfranc joint problem. We'll talk about it in the future slides. So I just wanted to bring home the fact first itself that you do not look at the X-ray first, you look at the patient, you do a history, you get to know what the mechanism of the fall was. Then you do a physical exam and you come to a diagnosis and then you look at the X-ray. So what you're covering today is just going to be something about the ankle and foot examination. I've already talked about the rest of the stuff in the first part. So something about, basics. So a basic anatomy is what you need to know, that ultimately the tibia is going to be articulating to your talus. The talus is going to be articulating to your calcaneum. The fibula does not play a part in this. The role of fibula is to help with some weight bearing. That is, it helps in an axial loading stuff. And it just weight bears somewhere around 10% of your body weight. That is what the fibula does. It does not rotate per se. All it helps is in providing a vertical kind of stability. That also not much. And then you have the talus, which goes on and binds to your navicular bone. And then you have a cuboid bone. The navicular then further articulates with the cuneiforms. And what we traditionally call as the hind foot is your talus and calcaneum, as shown in the figure. Then you have your navicular bone, cuboid bone, and three cuneiforms. That is the medial, middle, and the lateral cuneiforms. And then articulating with it is your metatarsals. Then you have your phalanges and not. So the cuboid, the navicular, and the cuneiform, those are the five bones. It will contribute to the midfoot, and the rest will be your forefoot. Now, first of all examination findings, you start with the inspection. So you inspect the foot and you look for any obvious deformities, laceration, and whatnot. You assess the gait of the patients because sometimes the deformities you will be only able to understand once the patient starts walking. For example, for a plantar drop, the patient will have a high stepping gait. And since he won't be able to dorsiflex his foot, he's going to land his foot with a slab. So unless the patient walks, you won't be able to pick all that foot drop pattern. So that is why assessing the gait is important. So once you really start doing the physical, all this comes into play. And palpate. Palpate, you have to palpate all areas and you are always worried about the point of maximal tenderness. It is not the region of maximal tenderness, it is the point. There's a one particular point that you are able to touch where if he's feeling the maximum tenderness, that is where you're supposed to be looking at. The patient can have a fully swollen ankle, but he's going to have definitively very few points of maximal tenderness, which is what you're supposed to be identifying. And some of the points that you shouldn't miss are the medial and lateral malleoli, the anterior talofibular ligament. If you remember the anatomy, it is the lateral part which has the talofibular ligaments attached to it. And the deltoid ligament, which is the strong medial ligament that is supporting the ankle. Then you're supposed to have a good palpation over your tibialis anterior, tibialis posterior, peroneal tendons. Then you're, sorry for the spelling, the Achilles tendon, of course. And then always a proper neurovascular examination has to be done. So these are something that you shouldn't be missing. Basically, you just go ahead and palpate all the areas, find out the points of maximum tenderness, and then you look at the X-ray and then you try to figure out what is going on with the patient. Because it is not a rocket science. Wherever there is a fracture, there is where you're supposed to be having the most pain. You're supposed to have a good grip on the calcaneum. Just hold the calcaneum and just squeeze it and see if the patient has some pain. Then you check for the navicular, you check for the base of fifth metatarsal, and you palpate all the heads from the first to the fifth metatarsal. You palpate each individual toes. You'll find some point of tenderness. And then movement. So coming back, we'll just go back and have a look at here. As I told you that the tibia articulates with the talus, that is the tibia-talar joint. That helps with your plantar and dorsiflexion. Then you have a talocalcaneal joint, which is called as a subtalar joint. That helps in inversion eversion, right? That is done. Now the midfoot. Now once you isolate the midfoot, if you want to isolate the midfoot, you have to understand that the heel shouldn't move anywhere. So you have to hold on to the heel. If this is the entire foot, this assuming this is the posterior part, this is the anterior part. The posteriorly, you will have to hold the calcaneum fixative in place, and then you move the foot in an antero-posterior direction or in an inversion position to check for midfoot pathologies. Right, and this is very important, especially when you think of midfoot injuries and your Lisfranc joint and all that. We'll again talk about it. So just again recapping, the tibio-talar joint helps in plantar and dorsiflexion. The subtalar joint helps in inversion eversion, and the midfoot joints will help. Will in its own has its own movements that almost occurs in multiple areas. So this midfoot joint, the one that attaches your tarsals to the metatarsal joint, that particular joint is what we call as the Lisfranc joint. And finally, you check the individual joints. Now, special tests that you can do is, one is for Achilles tendon integrity. All you can do is Keep the patient in prone position and just squeeze the Achilles, the gastrocnemius and soleus muscle. If the Achilles tendon is working normally, your foot should automatically plantar flex. It is a very easy sign. So, and some of the other specialties we have already talked about. Now we have the famous Ottawa ankle rules, which is again, it is very well shown in the picture where all you're supposed to elicit tenderness for. And very important for us to understand that this shouldn't replace your physical examination. This is just to let you know whether the patient needs an X-ray or not, whether you can safely discharge the patient on X-ray or not. It does not tell you what pathology the patient has. To understand what pathology the patient has, you should do a history and physical. Whether to do an X-ray along with it or not is what is going to be answered with your Ottawa and knee and ankle and foot rules. So you can see that it is of two parts. One is your ankle part, one is your foot part. Foot part mainly 2 points of tenderness you look for, shown in the figure. One is the base of fifth metatarsal. Second is the navicular bone. And then over the ankle, you have the medial and lateral malleolus. Preferably, they say to check on the posterior edge and also around 6 centimeters of length. You don't want to miss your fractures around that region. But again, this you shouldn't actually think about this. You should just go with the proper history and physical, so it automatically comes under all this. A fracture of the base of the fifth metatarsal is called as the Jones fracture. Then we'll be talking about calcaneal fractures. We'll be talking something about a Ellis fracture. So these three are the major things that I'm going to be covering today. So moving on to hindfoot injuries. So hindfoot consists of two parts. One is your calcaneum, one is your pars. And we are always going to be thinking of calcaneum. And more or less, since the time that we have been learning this, we know how this happens. Fall from height and axial load to heel. That is the mechanism that happens with it. We all know about it. And whenever you're suspecting a calcaneus injuries, the mechanism will be a fall on height onto the feet. And you're always going to be suspecting associated fractures. For example, a neck of femur fracture or some lumbar spine fractures and all, you should always be thinking about. Don't think that the patient has only broken a calcaneum. You should think of other causes as well. So that is one of the things, and it's the most common fractured tarsal bone, hence we are learning about it. And two types of fractures, one is an intra-articular fracture, one is an extra-articular fracture. Intra-articular fracture means that the talus calcaneal joint is disrupted, whereas in extra-articular, it does not involve the joint. And it automatically makes sense that an extra-articular is going to be less severe, whereas an intra-articular is going to be more severe. That goes without saying. So how do you actually look for it? This is the bolus angle. You can actually appreciate the normal calcaneum on the right side. You have the calcaneum, and as the line is drawn, there are two lines that are drawn. One is drawn from the superior part of the posterior calcaneum to the highest point, and the second line is drawn from the highest point to the superior part of the anterior process. So between the angle between this should be somewhere between 25 to 40 degrees. And if it is compressed, means that there is a fracture along with it. On the left side, you can clearly see a comminuted fracture of the calcaneum. Now, the question again comes, what is the management? Management is ultimately, it is left to the orthopedician's decision. One major problem with the calcaneal fractures is that your height reduces because naturally the calcaneum is compressed. So you're going to have some sort of a limb length discrepancy, especially when you start walking at all. So that is one reason why they surgically correct this. The other thing is once the talocalcaneal joint is disrupted, you can't fix it properly. So one of the few reasons why they do it is just to get your height right. The rest of the complications of long-term arthritis and long-term pain and all will definitely continue on for the patient. So once you get a calcaneal fracture, it is part and parcel of you till you live. So that is one thing. So regarding calcaneal fractures, these are the 1 or 2 points that I would like you to take home. One is that the most common mechanism is going to be an axial load to the calcaneum. And you should think of other fractures that the patient has, not just think about this fracture. Patient can have lumbar fractures. The patient can have some neck of femur fractures. So other fractures should be ruled out in this patient. especially if you follow the trauma code, it falls under severe mechanism of injury, then you will have to take other CTs as well for the patient as well. So basically, a calcaneal fracture means a significant impact. You should be thinking what else does the patient have. And clinically also, how do you just hold on to the calcaneum and you just squeeze it. If the patient has pain, there is a fracture. The X-rays might be normal, but you squeeze the calcaneum and it has tenderness, it means that there is a fracture. Which means if you want to diagnose a fracture, you need to take a CT. If you don't want to diagnose a fracture, fine, you can discharge. But again, just because you see a normal calcaneum and your physical shows that patient has significant tenderness means that there is definitely a calcaneal fracture. It does not mean that your physical examination is wrong. It just means that the X-rays do not pick up calcaneal fractures that quickly. So which is why physical examination is very important, especially as part of your routine angle examination, that you go on and hold the calcaneum and see whether there is tenderness for the patient. Right? So when in doubt, you always do a CT, and surgery is ultimately left down to your orthopedics. So this is what we are talking about, your bowler angle. Less than 25 degrees is again abnormal. So an intra-articular definitely needs an emergency. You need it to be shown to an ortho guy. But if it is just an extra-articular fracture, then you don't need to anything. You just need to follow the RICE and you need to just ask them to follow up on an OPD basis if it's an extra-articular. But again, extra-articular is not common. The most common type is going to be an intra-articular. So that is about calcaneum. And once we talk about talus, the talus bone is synonymous to your scaphoid, which means high risk of avascular necrosis due to poor blood supply. So that is one thing why you should invest this, because there's a high chance that this is going for avascular necrosis. And just like calcaneal fractures, it also can be missed on an X-ray, but depending on a clinical suspicion, you can take a CT to find out whether the patient definitely has a talus fracture or not. And this is also fall from height, except that one added mechanism is that it needs extreme dorsiflexion. So you fall your foot on an extreme dorsiflexion is where you need a talus injury, and it is usually a significant mechanism of injury. Low mechanism of injury and all will not cause this talus injuries. And again, there are two types. One which involves the, as you can show in this figure, one which involves the body, neck, and head. And the minor is anything that involves some other minor processes or something that it has. A lateral process fracture of the talus is called as the snowboarder's fracture. I'm stopping the discussion of snowboarder's fracture here because I've already discussed it in part 1. So talus again needs a severe mechanism of injury. It is not going to be broken in your small this thing and physical examination would include tenderness of the talus. Where does a talus lie? It lies on the anterior part. And this is not covered in your Ottawa rules, which is why you need a good physical to actually look into this. A patient having a tenderness on the anterior joint line, especially when you dorsiflex and all, you should be thinking of talus bone fractures, or you should be thinking of syndesmosis injuries. Again, syndesmosis injuries I've covered in ankle, so you may go back and have a look at the video if you want to. So again, talus injuries, just one point that I would like to highlight here is that it means extreme dorsiflexion, higher risk of avascular necrosis, and if clinical suspicion despite normal X-ray means that you can take a CT to look for the fracture. Again, you are suspecting the fracture, it needs an emergency ortho review because there is a higher risk of avascular necrosis. With that, we end the hind foot. Most common tarsal bone fracture is going to be a calcaneum. We have already discussed about that in detail. So midfoot. The joint that we are worried about is the Lisfranc joint. And this is not the parts of Lisfranc joint. This is just the parts of medial, midfoot. And again, coming back to the anatomy, it is divided into two parts. You can see the cuboid is one part along with one of the cuneiforms, whereas the rest of the two cuneiforms and the navicular, that is a medial and middle cuneiform with the navicular, will form the medial column. The lateral column is going to be followed by a cuboid and cuboid. And the fourth and fifth metatarsal joints. Sorry, the navicular and cuneiforms will follow. I'm sorry for it. The medial columns is your navicular and your cuneiforms. That is the medial and middle. And the cuboid and the lateral cuneiforms will constitute your this thing and followed by your metatarsal joints. Let me just have a look at it. I'm not sure. Yeah, we'll have a look into it. Huh. I'm sorry. I'll just come back to it and tell it again. The the cuboid bone and the last two metatarsals is your lateral column, and the navicular bones with your cuneiforms with the three metatarsal bones with that particular joint will include your medial columns. So it is not the once again I'll just say it's not the cuboid over there. It has to be the cuneiforms for the medial columns. And what is the Lisfranc joint? There is a Lisfranc joint complex over here, and it is typically described between the tarsals and the metatarsals, especially between the first and the second metatarsal. So between the first and the second metatarsal, there should be a ligament that connects the lateral part of the metatarsal bones to the medial part of the second metatarsal uh, bone. So that is what is typically your Lisfranc joint. And this entire thing can be called as a Lisfranc joint complex, that particular thing. But mainly when we talk about Lisfranc joint, we are worried about the space between the first and the second metatarsal at its proximal end. And there's a ligament again that connects between the metatarsal and the tarsal bones between those in a diagonal fashion. I'll show it if I have one more picture about it. And this thing should be thought of like the scapholunate of your wrist. Again, the scapholunate will cover wrist. I hope to cover wrist in further sessions. So in the wrist, you have something called a scapholunate space. So again, there the injuries can range from minor sprains to fracture dislocations. That is also what is happening here. The sprain joint can mean from sprains to fracture dislocations. It is like a wide spectrum of whatever wide spectrum of injuries the patient can have when he is having a problem in this particular area. And the important point is it can happen with the low mechanism also, which is a very important point that you need to take. But you talk about talus, you talk about calcaneum, it needs a high mechanism of injury, whereas here you just need a low mechanism of injury. And usually what happens is it is going to be a plantar flexion with an axial loading. So one common way by which these patients can injure is, for example, you fall into a foot hole. So your foot goes in first and then your body's weight gets transferred over. So that is plantar flexion on an axial load. Whereas dorsiflexion on an axial load will cause your talus fractures. Plantar flexion is going to cause it on the Lisfranc joint. Again, telling you that the Lisfranc joint is the space between your first and the second metatarsals. There's a ligament that connects the metatarsals with the tarsals over there, which is called as the Lisfranc ligament. There's also something called as a Chopard ligament, but I'm not going to be talking about it because of the less clinical significance that is associated with it. So plantar flexion with an axial load. And when to suspect it? When you do the clinical. When you do the physical, you need to move the midfoot and see what is the function about it. So as I told you, how do you do the midfoot? You stabilize the calcaneum and then you move the midfoot here and there. You do an inversion, you do a plantar and dorsiflexion as much as possible, and there is going to be pain on torsion of the midfoot. There is going to be pain on passive dorsiflexion or plantar flexion. These are some stress tests that you are doing to elicit pain over the Lisfranc joint. And another important point is the ecchymotic patch that you can see over here, especially over the plantar surfaces. This is suggestive of a Lisfranc injury. And again, I'm telling you that a medial midfoot pain is a red flag sign when you are coming to examination of the foot. A medial midfoot sign is a red flag sign because therein lies your Lisfranc joint, therein lies your tendency to do. Right. And you have a classification that is based on the Nunley classification history. You don't need to know about that. And where do you look for it? Look at widening between the metatarsal base of first and second and third. But let us just stick on to the first and second for the time being. And there can be some avulsion fracture near the second metatarsal base because of the ligament that goes along with it. Sometimes it can pull through and can cause an avulsion fracture over there as well. If you have high suspicion, again, you go for a CT because these are complicated structures. You can see on the X-ray over there that there's a widening of the space. A widening of the space And this widening can be even as small as 1 millimeter. More than 1 millimeter is a significant pathology that is being hidden there. Somewhere around 2 millimeters, you need a surgical correction. So, which is why you shouldn't be missing all this. And this can be easily missed by us. If you don't do a proper physical, you don't look at the plantar surface of the foot. We rarely do check. Maybe the patient has his socks on. So you have to remove the socks and see whether he is having any tenderness or anything over there. And look at this particular X-ray. This particular X-ray clearly shows that, dude, there is a widening of the space between the first and second metatarsal bone. You need to be thinking of a Lisfranc injury. Right. And coming back to this X-ray that we had, this patient, this is the first X-ray that I showed, the sesamoid bone fracture that we are talking about. A patient looking at this X-ray might think that this is a sesamoid bone fracture, but a patient who does a history and physical will know that we are actually suspecting a Lisfranc joint problems in this patient. Because this patient actually had, like I told you, a fall he fell into a gutter or something. He had the typical plantar flexion with an axial load mechanism, and he has tenderness over that particular area as well. And on doing the provocative test, there is pain on passive dorsiflexion of the midfoot. There is some pain elicited while you are twisting the foot. So whenever you do X-rays, if the patient is able to ultimately, what is the function of a joint? It needs to meet. What is the duty of a joint? It needs to have some function. So what is the function of the foot? It has to bear weight. And you can do a weight-bearing films for this patient to better increase your prognostic yield. And this is the same X-ray of the patient after you ask the patient to bear some weight, and then you repeat the X-ray. And you can see that there is a clear space over there. So a patient who does a history and physical will understand that this is a Lisfranc joint. He will order for a weight-bearing image so that the Lisfranc joint can be found out. And you won't be labeling this patient as having a sesamoid fracture. If you do a clear physical, you will anyway understand that the patient does not have tenderness over there. So that is just talking about the Lisfranc joint. And the key important point is that you need to look for compartment syndromes. And where is compartment syndromes common? It is common at the foot. It is common at, the lower leg part. It is common at the forearms. It is common in young, healthy individuals. In young, healthy individuals, whichever fracture is there, keep in your mind of a differential of compartment syndrome. It does not happen that often in infants. It does not happen that often in elderly because of the less muscle mass that the patient has. What happens if you miss? Abnormal gait will be there in the patient. Early osteoarthritis might be there in the patient. Patient is going to have chronic pain, which is not good outcomes as far as the patient is concerned. And medial midfoot pain is a red flag sign. So in the hindfoot, we talked about calcaneum, talked about 3 or 4 points about it. Lisfranc, I am talking only about the Lisfranc in the midfoot because that is what is the most important. I am coming on to forefoots. Forefoot includes your metatarsals and your phalanges. So you naturally look for point tenderness and all that. And the base of the fifth metatarsal fracture is called as your Jones fractures. And the Jones fractures happens at the metaphyseal-diaphyseal junction. So if there's a fracture that is proximal to that, you call it as a pseudo-Jones fracture. If there is a fracture that is distal to that, it is a shaft of fifth metatarsal fracture. Why is it important that you identify the difference between a pseudo-Jones and a Jones fracture? Is that a pseudo-Jones will heal on its own. You can just ask even if you don't miss it is fine. The patient will walk on its own. And more importantly, if you misdiagnose it as a Jones fracture. In a Jones fracture, you need the patient to be in an immobilized position. In a pseudo-Jones fracture, you need not be. So in a pseudo-Jones fracture, if you are putting the patient on a cast, it is going to cause unnecessary immobilization of the limb, which can lead on to problems later on down the road. It can lead to muscle atrophy. It can lead on to some amount of stiffness and reduced movement, and whereas that is absolutely necessary for a Jones fracture. Why? Because a pseudo-Jones fracture is a fracture of the metaphyseal bones, and the metaphyseal bones have rich blood supply, if you remember, right, and they can heal very quickly. Whereas the diaphyseal fracture or something like a metaphyseal diaphyseal fracture, they don't heal that well. So Jones fracture needs prolonged immobilization. They need immobilization for around 6 weeks. For full function, they need around 6 months. So that is why it is important that you identify that it is not just the base of the fifth metatarsal that you're looking for. You're looking for where exactly the fracture is, whether it is at a metaphyseal, diaphyseal junction or proximal to it. If it is proximal to it, you just ask the patient to walk as much as pain allows you to, give him some NSAIDs. Whereas if it is a Jones fracture, you put him on a cast instead, not a cast, a slab. So those are some of the things, and mechanism is going to be a direct injury over there. They are going to drop some heavy objects on that particular part, and you are going to have a tenderness there. And the fifth metatarsal fracture tenderness naturally comes in your Ottawa rule. So if you follow the Ottawa rule, you're not going to be missing this. And if you follow the Ottawa rule, naturally you're probably not going to miss because you're going to palpate the navicular bone. A little bit more distally, maybe you might end up palpating and you're not going to miss the Lisfranc adjustment, but it's imperative that you do. So this, if we can see, is a subtle fracture line that can be seen at the base of the fifth metatarsal, and there is nothing much that you can do about it. This is a pseudo-Jones fracture. This again, a transverse line that is not at the metaphyseal diaphyseal junction at both parts. You are not going to be missing this fracture. This is a pseudo-Jones fracture. The next picture, you're obviously not going to miss it because it is associated with some dislocation. It's a pseudo-Jones fracture. You need an orthopedic review, but it is like a benign fracture that can happen. This particular fracture, I took it from tendinally. This is your metaphyseal diaphyseal junction fracture. This is what we call classically as the Jones fracture. So just talking about Jones fracture once again, it is a metaphyseal diaphyseal junction. It comes under Ottawa rules. You just need to make sure that it is at that particular junction. If it is proximally, it is called as a pseudo-Jones fracture. It heals quickly, so you can ask the patient to wait back, give some NSAIDs. Whereas for Jones fractures, you put the patient in a cast instead. That is what the difference is. And with this, I am essentially completing my topic on this. The rest of the common fractures and all that you're going to be finding, you're anyway going to be finding it, and you're going to be referring to an orthopedics guy. And these three fractures is what I would like to talk about. One is the Jones fracture, pseudo-Jones fracture. Second is we talked about detail about the Lisfranc fracture. And then we talked about the calcaneal fracture. That is, you have to look for other fractures as well when it happens. And that's it. That will be the end of my discussion today. If you have any doubts, I'll take it. Else we'll call it a day. If Neil sir wants to add something, he may add.